He's a professor of obstetrics and gynecology in Tübingen, working together with Oliver Kagan. He's one of the best specialists in Germany on perinatal medicine and gynecological ultrasound, and he has many fields of interest, but he will now speak in his talk on ultrasound features of common aneuploidies to start as a warm-up for this syndromic day. So please, Marcus, now let us hear your talk.
Dear colleagues, dear chairman, I'm very proud and honored to present ultrasound features of common chromosomal aberrations in the second trimester. And this is really a classic in prenatal medicine. I think it's 20 years ago that I firstly heard about genetic scan in the second trimester in a lecture. And perhaps some of you say, okay, then it's quite old-fashioned. Yeah? And I hope I can show you that it's still necessary to know the key signs to detect these chromosomal aberrations. And I start like yesterday with rules of thumb. If you want to find something, you only find what you are looking for. And then when you find it, then you have to recognize it, and you only can recognize what you know, and you have to differentiate it. And then you can see that in this painting from the beginning of the 16th century, you see a child with a Down syndrome. And this leads us to the question, what are common chromosomal aberrations? So 3 to 5% of our babies, of our born babies, have fetal anomalies. And this is a very important number. Only 10% of these anomalies are provoked by chromosomal aberrations. So this is very important to explain to parents that chromosomal aberrations are not the main reason for anomalies. And if we define these chromosomal aberrations, we see that half of them is trisomy 21. So this is our main issue. And 1/3 is trisomy 18 and 30, and 10% is Turner syndrome, and 10% is the rest, including triploidy. I like this picture of the publication of Borel because it has some really important key messages. What you see is that ultrasound is necessary to detect fetal structural anomalies, and these structural anomalies are responsible for the majority of the fetal problems. But on the other side, there's a big field of genetic causes of anomalies. And these can be divided in 3 aspects. And the first one is the chromosomal anomaly we want to talk about today, which is referred to karyotyping. But we also have microdeletions and microduplications, so submicroscopic anomalies, which can only be detected in microarrays. And we have single gene disorders, which nowadays will be analyzed in whole exome sequencing. So what you see is that the overlap of a sonographically phenotype and chromosomal anomalies is quite big, but that it decreases to single gene disorders. In single gene disorders, you only have in rare cases a sonographically visible and detectable phenotype. So key message is not every structural malformation has a genetic cause, and not every genetic disorder has a recognizable phenotype. But when we look on the trisomies, we have to see and admit that second trimester screening is not the optimal way of screening. Yeah? We can begin screening at 10 weeks of gestation with cell-free DNA, and you see we have detection rates from 97 to 99%. When we see our classical first trimester screening as combined test, we have detection rates of 90 to 95%. And when we see our diagnostic tests, the chorionic villi sampling at 11 weeks and the amniocentesis at earliest 60 weeks, we have then we see that the second trimester screening with a detection rate of 70% is not the optimal way. And this can also be seen in the development of the indications of diagnostic punctures. Here we see a nice study from Australia, and they show that in the 18 and 19s, the advanced maternal age was still with the main reason to do a needling. And there is a slow rise of the indication of second trimester ultrasound and finding of malformations, but you see, it never was bigger than 25%. Yeah, and just nowadays it's stable at this 20% level. But we see this uprise of first trimester screening, which is now the main cause of diagnostic tests, especially in the first trimester, and has overwhelmed the triple or quadruple test. So what are the reasons to screen for trisomies in second trimester? Who needs it, and why is knowledge still necessary? So there's a small minority of patients with late detection of pregnancy, with borderline risk in the first trimester screening, and you want a second line test, or you have repeated test failures or inconclusive results in it, which can lead to scan in the second trimester. But I think the main importance is that if you find a fetal anomaly, you always have to think about, should I offer genetic testing? And if so, what genetic testing? You have the choice between classical karyotyping, microarray, and whole exome sequencing, and you must think about what is most efficient, what is the fastest way, what is the most cost-effective way of this testing. So, and when it looks like a trisomy, test for trisomy. And when not, test more complex. I think this is the best way. And this is the reason why we still need to know the image of a trisomy. And we have to differentiate between hard markers and soft markers. Yeah? And the search of these markers is a genetic scan. And hard markers are major anomalies with a high association to aneuploidies, and they have a relevant influence on perinatal outcome of their own. One example is this omphalocele. You know, this has a high association with trisomy 18. In contrast, gastroschisis don't has a relation to chromosomal aberration. And then we have these soft markers, and sometimes they can really be annoying, but they are our daily work. They are ultrasound signs that occur frequently, even in healthy fetuses, and have no clinical value of their own. But they have a higher prevalence in fetuses with aneuploidies compared to unaffected fetuses, and therefore they increase the risk of aneuploidy, but in a variant degree. Let's look for an example. Here we have a 39-year-old woman with her first pregnancy. It's a twin pregnancy, a dichorionic twin pregnancy after IVF. And she was referred in the 24+3 week of gestation due to suspicion of polyhydramnion in fetus 1 and clefted polyp in fetus 2. Let's focus on fetus 1. And here you see the profile. And what you can see is that you don't see a nasal bone, that we have this prefrontal thickening, and that the mouth is a little bit open due to macroglossia, and that in the whole, the profile is a little bit flat. And when you make a 3D, then you can see that the eyelid axis is a little bit ascending to the lateral borders. And when you make the axial plane of the head, you see that the cavum septipellucii is quite wide, and that we see here a thickened nuchal fold. In the abdomen, you see this typical double bubble sign, which is indicative for duodenostenosis or atresia. And then you measure the extremities, and you see that the femur length is on the 9th percentile and the humerus length at the 5th percentile. You see as reference the other twin. So now you have already the suspicion that this is trisomy 21, which could be confirmed. And you see this combination of hard markers and soft markers. And when we talk about hard markers for trisomy 21, I think we can reduce it to 3. The first one are heart defects. In 45% of trisomy 21 fetus, you will find heart defects, especially this one, the atrioventricular septal defects. You already had several lectures on heart defects, and this is the most common. And if you find it, the association to trisomy 21, the probability of a trisomy 21, if you find this heart defect is 50%. And even if you find a tetralogy of Fallot, it's 7%. So a short repetition on this heart defect, because it's the most frequent heart defect you can find in uterus. Focus on this cross inside the heart. This cross built by the septum and the 2 valves, with this small step between the small distance between the 2 valves. And when you see these 2 examples, you see that the valves become to one line and that there is a kind of hole in the center of this cross. And another easy parameter is to look for the length, the relation of the length of the atria and the ventricles. And normally it should be 1/3 to 2/3. And in AVSD, it's often half-half. Second hard marker, like in our example, is gastrointestinal atresia or stenosis. 10% of trisomy 21 fetuses have it. And the most frequent gastrointestinal finding is the double bubble signs, duodenostenosis or atresia, which can be really a gap or stenosis provoked by the pancreas. And what we see in this double bubble sign is the dilatation of the stomach and the proximal duodenum between pylorus and stenosis. But be careful, the manifestation is mostly the course of the second half of the pregnancy and only rarely before 20 weeks. So keep in mind the course of the pregnancy. But when you find it, the probability of a trisomy 21 is above 30%. And a small hint, when you see the sign, don't think it's obvious to the patient what you see. You think, oh, it's a double bubble and it's a duodenal stenosis, and the pregnant woman thinks, oh, it's my baby's fine, it's smiling, it's a face. The next form of gastrointestinal obstruction is the esophageal atresia. Here you also will have a lecture. And here you see the typical pouch sign and the non-visualization of the stomach. But you know, there can also be fistulas, which are much harder to detect. And the last forms are the lower bowel stenosis and especially morbus Hirschsprung in the colon. And they are often late or postnatally diagnosed. But when you see them intrauterine, think on trisomy 21. And the third hard marker is the non-immune hydrops fetalis. But when you see this, you have to open your mind for all chromosomal aberrations. But often you will find trisomy 21 as a reason for this problem. These were the hard markers. Now we come to the soft marker, and the literature is quite big concerning these soft markers, but I think we can focus on this excellent meta-analysis, which includes 48 studies, and they focus on these soft markers, and I think I can confirm that these are the most important. And first of all, we want to pick out these 4 markers because they're quite frequent. You have this intracardiac echogenic focus, the mild hydronephrosis, short humerus, short femur. And then it's very important to look what is the importance if it's isolated. And here you can see it's not important. It doesn't increase the risk. Okay, then we can focus on the other. And the first one is ventriculomegaly. And when you have a bilateral ventriculomegaly, you see that the risk increases about the factor 4. But what we also see is that the detection rate is quite low. So it's only small minority of the trisomy 21 fetuses who offer this sign. It should also be remarked that the ventriculomegaly is normally mild or moderate, and only in very rare cases you really find a hydrocephalus. The nuchal fold also increases the risk about the factor 4, but it has not the importance of the first trimester. You see the detection rate is only 26%, but it's for sure its risk increasing. And I know that Ravi Shawi is here, and not only for this reason, we have to talk about the ASA, the aberrant right subclavian arteria. And here you see normal findings. And normally on the right side, you have the truncus brachiocephalicus, and you see this curved course of these cranial and cervical vessels in front of the trachea. And this is an ASA, and you see that in this case, we have 4 vessels deriving from the aortic arc. And you see that this aberrant right subclavian artery has a straight course behind the trachea. That's the way you can find it. And if you have this finding, you see that it's indicative for trisomy 21 with detection rates, cumulated detection rates of 26%. So it's an additional marker. But in this study, they don't see it as an isolated marker. So if you have isolated ASA in this series, they don't find cases with trisomy. But always be careful with these studies, because the diagnose that the rest is okay is quite challenging. Yeah, so always keep in mind that this is really an important soft marker. And then one of the most important soft marker is the absent or hypoplastic nasal bone. And here you see that the risk really increases highly, about the factor of 6 to 7, and that the detection rate is now about 60%. To evaluate the nasal bone, look that your probe is parallel to the nasal bone, and normally you should have a good look on this bright bone. And here you see that it's missing. Yeah, and here you see one recent published study, but we have a big amount of studies like this. And you see that the relation to chromosomal abnormalities is 77% in this series, in this population. But even in isolated cases, you had about 11% of chromosomal aberrations, mainly trisomy 21. But do we have other facial markers? Yes, we have. Normally, the profile is flat, and this is caused by mid-facial hypoplasia. And you often find this prenasal subcutaneous thickening. So how to quantify, how to measure it, and what are the detection rates of the single markers? So that we already have said, that hypoplastic nasal bone has a detection rate about 60%. There are studies describing this FMF angle, which quantify the mid-facial hypoplasia, and then you have a detection rate of 65%. You can measure this prenatal edema, this thickness. If it's above 5 millimeter, you have a detection rate of 73%. And when you use a way of Tübingen, you use this prefrontal space ratio. So you have this line across the borders of the maxilla mandibula, which should have a good distance to the front of the profile. And when you see that the distance to the skin is very small, and the distance here to the frontal bone is quite big, then you can build this ratio, and you see that we could reach a detection rate of 79%. And the last aspect is you can use the relation of the prenasal thickness to the nasal bone. And if the nasal bone is very short and this is very thick and you build a ratio, then you can reach detection rates about 80%. So if you put all this together, you see we have ways to quantify the evaluation of the fetal profile. Last aspect, because we mentioned it, if you look how wide is the carbon septic pellucidity in the normal fetus in 20 weeks, it should be around 4 millimeters. If it's quite above the 95th percentile, the sensitivity for trisomy 18 is 90%. So it's a very frequent finding in trisomy 18, and in trisomy 21 and 13, it's 40% of sensitivity. So now we come to the next chromosomal aberration, the next case. It's a 29-year-old woman in the first pregnancy at 25 weeks of gestation, and she was referred due to the suspicion of IUGR under the third percentile. So very small baby, and we can confirm this IUGR. And here you see the head shape, and what you see is that it's quite flattened at the back, at the area of the occipital bone. And in addition, you see this cyst of the chorioid, of the plexus choroideus. And this is called the strawberry sign. And then we see, okay, here's an omphalocele and a cytus. If we look on the heart, we see a big ventricular septal defect. When we look in the head, we see a genesis of the corpus callosum with the typical teardrop sign. Yeah. And when we look on the face, we see lithognathia, and that the ears have a quite deep insertion. Looking on the extremities, we see this typical clenching of the fingers. So especially the second and the fifth finger is across the other. Looking on the feet, we see two different malformations. On the top, you see the typical rocker bottom feet. So the form of the foot is convex. And here is a typical sign of a club feet. And if we put all this together, we have the typical image of a trisomy 18. So these are the anomalies you typically can find in trisomy 18. So IUGR is very, very frequent. Central nervous system anomalies like the agenesis of the corpus callosum is very frequent. Facial anomalies, especially lithognathia, or clefts is very common. Heart defects, almost all of them have them. Omphaloceles, renal anomalies, even spina bifida in 12%. And the last sign is the most common sign, the skeletal and the findings in the extremities. I showed you the clenched fingers, the malformation of the foot. And this is another aspect, the aplasia of the radius, also very frequent in trisomy 18. So it's much rarer than the trisomy 21, but what we can say is that all fetuses with trisomy 18 show malformations in the course of the pregnancy. So here, the ultrasound gives us the way what we have to look for. Case 3. Now we are at the 90+0 week of gestation, and she was referred due to early IUGR and the suspicion of hydrocephalus. And when we look in the head of the baby, we see, no, it's not a hydrocephalus. Yeah. What we see is this U-shaped ventricle. Yeah, and we don't see separation of the two halves of the brain, and this is a allobar holoprosencephaly. And if you find this, you have to expect to find also facial malformations, and you see them. We have these narrow eyes, these hypoplastic eyeballs. We have only one nostril, and you see this atypic profile, which is really flat with a small pointed nose. And when we look on the hands, on the feet, you see 6 fingers and 6 toes. And here on the heart, you see a heart defect. And again, it's a big ventricular septal defect with white spots. And this is quite typical for this trisomy, this form of trisomy. You see these hyperechogenic enlarged kidneys with reduced differentiation between medulla and cortica. And this is a trisomy 13. Yeah. And you see very, very typical is this holoprosencephaly. Yeah. And these associated facial anomalies. Yeah. Which cannot be overseen. Heart defects are very frequent. Limb defects, especially additional fingers and toes. These renal anomalies are quite frequent, and it's very frequent that they are very small. It's even rarer than the trisomy 18, but it's similar. They show all malformations in the course of the pregnancy. And this you can find easily in the first trimester. Yeah? This is a study from Tübingen, and we have analyzed how is the detection rate for trisomy 18 and 13 in the first trimester. When you look for anomalies and when you look for NT nuchal translucency above 3.5 millimeters, and you see 95% detection rate only using first trimester ultrasound. Now we have talked about these 3 trisomies, and these are really the common aneuploidies, yeah, and they are age dependent. Yeah. Now we come to the last 2. They are the Turner syndrome and the triploidy. And you see they are rarer, but they are not age dependent. So there can also be very, very young mothers with these problems. And typical for the monosomy X, or so-called Ulrich-Turner syndrome, is that you have this hydrops, this really extended cystic hygroma. And even in the first trimester, you have always enlarged nuchal translucency above 3.5 millimeters. And if you find them in the first trimester, you have to counsel the patient that 97% at least of these cases will progress to extensive hydrops and intrauterine death in the second trimester. And the surviving minority has, this is a good thing, normal intelligence and normal mental development. Yeah, but they often have ductus venosus anomalies. They have still these edema in at hands and foot, and as the most important complication, they often have this stenosis of the aortic isthmus. So the development can be fine concerning the intelligence, but there are other disorders to keep in mind. And the last chromosomal aberration we want to talk about today is triploidy, which is quite rare, and typical is this very, very early IUDR, even in the first trimester. And what's very typical, it's this pronounced head-thorax discrepancy. It's almost half-half. And often you find a striking placenta. And this depends on who has given this additional set of chromosomes. Is it from the father? You see a molar placenta, and this can provoke even early placental problems like preeclampsia or HELLP syndrome in the first half of the pregnancy. And when it comes from the mother, you have typically a very small placenta and a very early IUGR. But in both ways, the prognosis is lethal and they cannot survive. So let's come to the end and to the summary. What is the role of ultrasound in diagnosis of common aneuploidies today? So for trisomy and trisomy diagnostics, this has almost completely shifted to the first trimester. This we have to admit. But you have to check for plausibility of ultrasound findings with previous screening results when you do a second trimester. And when you find malformations, you have to think about what is the genetic workup. And ultrasound has a central pilot function in the choice of your genetic workup methods, which should be used. And when it looks like a trisomy, then you have to test a trisomy. And I hope I could give you an overview over the common chromosomal aberrations. And thanks for your attention.
Thank you, Mark. Thank you, Marcos, for this very detailed and interesting approach demonstrating the most common aneuploidies and how their ultrasound appearance is in the second trimester. So the next common condition, the most common deletion, is 22q11 syndrome. As you know, I've been working on this field of interest since more than 20 years. And I will give them now the next presentation on 22q11 ultrasound features. Good morning, dear colleagues. In this talk, I will be focusing on the deletion 22q11 syndrome and its ultrasound signs. There are several reasons why this abnormality is important, because this deletion is the most common deletion in humans, for it is the second most common genetic cause of congenital heart disease, second to trisomy 21. It is the most common genetic cause of psychiatric diseases in adulthood. It can cause a neonatal emergency because of hypocalcemia, and its incidence is quite high. So it is even more common than trisomy 18 and 13. I'm sure some of you have seen these cases or have seen fetuses where the diagnosis was done after birth. Now, this is a nice scheme showing why is 22q11 so interesting and difficult. This is a metaphor of 6 blind scientists asked to analyze an elephant by examining separate parts. So one examining the trunk, the other one the ear, the third one the leg or the belly. Everyone reports, let's say, an exactly description, but no one of these was able to see the big picture. And this is a nice allegory to describe why 22q11 is so important, because it can appear with different entities. And interestingly, this allegory was used as a symbol of the 22q11 International Society. In other words, we will not have one single sign, we'll have separate signs and we'll put them together. And for years, I was saying that the catch-22 used as a metaphor to understand what is the abbreviation of this disease, like cardiac anomalies, used for years, but actually it looks like a chameleon appearing with different colors. But in the meantime, I'm rather using the example of the puzzle. So look at now synonyms of this disease, and you understand now the comparison with an elephant. It is called the George syndrome, but it has different names, and the names are too different, and they were different diseases. But since it was found that all had at the end a 22q11 deletion, they were merged into one group. So in other words, these are different manifestations leading to different syndromes in the past. This is why the International 22q11 Foundation decided to run a campaign called Same Name Campaign. This is why today we don't say Takao syndrome or Kehler or Svensson syndrome. We say 22q11 deletion syndrome, or DS. Now, the problem is if you are using a karyotype, you cannot detect this abnormality. So the abnormality is, you see the 22 looks normal, and the long arm of the 22 is too small to detect this deletion because it's called macrodeletion. This is why you need to use either a fish sonde or a probe, or to use the microarray. I'll show you how will this work. The geneticists, when they run the FISH probe, they take a label probe to localize the 22 chromosome, and they take a targeted probe to localize the 22q11 region. So, and this is how it appears. You see here, the red one are showing the 22 chromosome, and the green one, sorry, and the red one shows the DiGeorge critical region. This is a normal fetus, and this is from a fetus with deletion. You see, it's on one of the chromosome there is the missing information, and this is how it's detected. So this is why if you see a problem and you want this macrodeletion to be detected, you need to ask the geneticist to use the probe, especially for this condition. Now, there are some companies offering also NIPT for this condition. I think there is a place for NIPT only in first trimester as a screening if you want, but you still keep in mind you may have let's say a low, quite low positive predictive value, and the detection rate is in many companies between 70 and 80%, but not 100%. This is why I will not recommend using it when you have a heart anomaly detected. This is why you need to have an invasive procedure and confirmation. Now look at now this nice scheme from this overview on 22q11 deletion syndrome, showing that it's not one organ like the heart or the thymus. It is a multi-system disease, including the immune system, the bone system, the brain, and the palate, and so on. And this is why today I will focus on three aspects. Let's start with the heart. So look at now, for the heart is the central organ affected in this disease, but some are so mild that you will have patient adults having this condition and inherited to the fetus. But in addition, this heart anomaly can be associated or combined with other abnormalities. So let's start now, and you see here that in my version I will focus more on the version of showing you a part of the puzzle. So the first part of the puzzle would be cardiac anomalies. And you see the list of the cardiac abnormalities is so clear. This is the so-called conotruncal anomalies explained by the embryology and development of this abnormality. So it is the interruption of the arc truncus communis and these conotruncal anomalies. Typically, the good message is that you see them almost all of these. The most common one with the 3-vessel and trachea view, and in addition, you see later on that we'll have here also the thymus seen. And the risk is increased if you have this abnormality in combination with the right aortic arc or the aberrant subclavian artery. So if you find, let's say, a tetralogy of Fallot with an ARSA, it increases the risk for 22q11 higher. So, and let's see now some examples. So this is here an example of an interruption of the arc. Instead of having the typical V sign, you have an interruption. You don't see the continuity of the aortic arc, in addition to the dilation of the pulmonary artery. Please note that there is no thymus in this fetus. You see here on a video clip how it looks like, and you see the clearly or a small thymus behind the sternum. The other disease I told you is 40% of the cases is the typical dilation of the pulmonary arteries in absent pulmonary valve syndrome. The other disease is the common arterial trunk. In 30% of the cases, you will find this deletion 22q11. You see here the four-chamber view may be appearing normally. Sometimes you have right-sided descending aorta, and you see here the typical bifurcation of the common trunk. So when you see this condition, or this is another example of a common trunk where you see that there is a common valve overriding on the septum, septal defect, and the bifurcation to both. When you see this condition, keep in mind 1 out of 3 is going to have an association with the 22q11. Now let's come now to the next part of the puzzle. This part is the thymus. You see this person, this is DiGeorge, a pediatrician who was the first to describe that in thymus aplasia is associated in this disease, and this is why the disease were called for years DiGeorge syndrome. But we know in the meantime it's present in 80% of the cases. So when you discover an absent thymus or hypoplastic thymus, think of this condition. So I remember it was in the mid-90s, 95, 96. This was my first patient on the right side, showing dilated pulmonary arteries and no region in front of this, typical for absence of the thymus. And this is where I started working on this thymus. At that time, I had to ask my geneticists if they can find a probe for to check for this disease, and we detected our first case of the George syndrome at that time. And you see here, if you want to demonstrate the thymus, it's quite easy. You need a high resolution probe, and ideally you will start, if you have not seen it before, so around 25, 26 weeks, because you see clearly that the thymus is more hypoechoic in comparison to the lungs. And this is here, we put our first study, analyzed